is on webinar is on impact of COVID in Asia and the situation of vaccine inequality in Asia is something which is being organized by Global Call to Action Against Poverty, SAAPE, South Asian Alliance for Poverty Eradication, People's Vaccine Alliance Asia together, and we have also other co-organizers. I'll also read out the names of our other co-organizers. Thank you for being here. I'm Pradeep Besak, the Asia coordinator of GCAP. So colleagues, you may know that we are working on this issue for last 3 years with COVID for last 3 years and on vaccines for last full 2 years almost. We started our work on vaccines in Asia at the global level. In fact, People's Vaccine Alliance started it a little early toward the end of 2020, 2021 beginning. In Asia, we almost picked up by Feb and March 2021. We started PVA chapter, People's Vaccine Alliance chapter in Asia, GCAP, SAAPE, APCASO, Oxfam, ActionAid, other colleagues came together, and we thought that we'll have a broader alliance to work on this issue, because it was probably sensed that there will be vaccine inequality in terms of distribution between rich and the global north and global south. We have worked incessantly on the issue, highlighting on the social media, highlighting on the media, ground level mobilization and all. And I think that in these 2 years of work, there are some results, though not at level of our expectation, but definitely there have been some changes. For example, US changed its stand to support the TRIPS waiver on vaccines, followed by other countries who were initially reluctant to do it. The proposal, in fact, was put forward by India and South Africa to do a intellectual property waiver on COVID vaccines, test and treatment, all of those. And they told that with this only we can make the globe fully vaccinated. But then it was not cutting ice with the rich countries. US first supported it, is followed by France, Greece, Norway, and other Italy. So in the complex geopolitical scenario, we cannot claim this is because of us only, but we are so that our work must have brought impact on these governments, not only the rich country government, but also the developing countries. In Asia, we have always attempted to influence the 3 rich countries, South Korea, Japan, and Singapore. Our colleagues in Japan and Singapore continuously engaged with their governments to change their stand. These are the countries who are opposing, either were opposing or were not clear or were fence-sitters on the issue. But eventually they also followed toward the line. So we do have some achievements. In the WTO Ministerial Conference in June, we had the TRIPS waiver adopted. In fact, WTO called it as a TRIPS waiver. In reality, when we critically saw the resolution, we found that it's not actually intellectual property waiver. It's more lenient patent regime was put in place, and that too only in vaccines. So that's a half achievement for us. We'll have a long way to go. Let me, colleagues, give me a minute. Let me, colleagues, take you through the list of co-organizers and also read out the agenda. Okay, let's see. So it's GCAP, SAAPE-PVA, Asia-Pakistan Development Alliance, WADA and Thoda Abhiyan, NGO Federation of Nepal, Noakhali Rural Development Society, Cooperation Committee of Cambodia, Philippines Rural Reconstruction Movement, Asia Dalit Rights Forum, Asia-Japan Forum, and One Singapore. These are the co-organizers. And then let me also quickly take you through the agenda. I'll do the introduction, and we'll release a video, last mile vaccination. Just after this, with this work which is done by Rupayan, one NGO. They did this under a geo-NGO partnership on in a government program, and they vaccinated people in very hilly terrain of Odisha, my province in India. Then we'll have presentations of position papers on COVID and vaccine inequality. We have 9 papers, 7 country papers, 1 regional level paper, and 1 South Asia level paper, which is on Dalits. Then we'll break for question and answer for some time. Then our colleague from People's Vaccine Alliance Asia, Lance Espacio, will present the future course of action. In 2 years of work, we have realized that we'll also need to change our course a little bit, something he will discuss. And then we will try to churn out a joint statement from the webinar where Lange will take the lead and Resma will give us the vote of thanks. So colleagues, without any delay, let me go to the next agenda. So all colleagues who are presenting are requested, presenting the position paper are requested to keep it to 5 minutes. Not more, but we have 9 papers. The webinar is of 1 hour and 45 minutes. 5 to 6 minutes will do. You can share your PowerPoint. So let me go to share the last mile vaccination video. This is, as I told, this being the work is done by a Rupayan NGO, which works in Odisha province of India. Let's see the work that they have done, how difficult it has been for them to reach the hilly terrains and vaccinate people there. Colleagues, can you see my screen now?
Yeah.
Yeah, okay.
Yes.
When Odisha, a state in eastern India, fought back the onslaught of the COVID-19 pandemic with vaccines in 2021, the government faced a major hurdle in inoculating people in hilly areas inhabited by the indigenous communities. Kalahandi is one of the most tribal-dominated districts of Odisha. Low literacy, superstitions, and language barrier played a key role in contributing to vaccine hesitancy in the district. This time, NGO Rupayan took the challenge to achieve last-mile vaccination in Kalahandi's Junaghar block in GEO-NGO partnership. The vaccination drive was undertaken as part of the government's Har Dar Dastak campaign. Junaghar has a population of around 0.19 million, a majority of them belonging to indigenous communities. Determined volunteers trekked hilly terrains and navigated through communication barriers and superstition to achieve nearly 100% inoculation in the block. Later, a delegation of Global Call to Action Against Poverty, GCAP, visited the block to interact with locals on the vaccination drive and observed how difficult the task was.
On our way to Lakhnapara Gram Panchayat, going up hills. This is the area. It's very inaccessible, difficult for the team to come and vaccinate people here. Somehow managed to ride a bike till this point. In the midst of the hill. And then there is a tip. And then I have to slide down to get into the village. So we have already walked around more than half a kilometer. Have to walk a little more. And at this point, almost mobile connectivity goes off. Going down to reach the concerned village.
Lakhnapara is a sleepy village cradled in the lap of nature. The villagers are mostly dependent on forests and agriculture for their livelihood. The highest educational qualification here is of Standard 5. A volunteer from the neighboring area teaches the children here. The village doesn't have regular electricity supply.
This is Lakhnapara village, which is a very remote village in forest area. From block headquarters, in fact, we came about just by bike And then to reach this village, we almost have to trek for 1.5 years. Also, some felt that they lost their potential. Tika nahi chanti mausi. Tu jana lo? Kiye kahila naba katha tika? भय लागिଥିଲା टीका नबाको भय तो करूथिलो आज्ञा वैक्सीन नौच बाकी लोग मन डरे मुडे ही कर खराब ही दोचर बोली कहउथिले सेते लागि आज्ञा हम भीतर डर भीतर जेंटा भय करबाटा करूथिलु ना बड़ बड़ लोक माने बुझैला एमती आपन को बोली अफसर मन बुझा लागे तो बुझना आर सेते वैक्सीन नल ना आज्ञा प्रथमे राजी नहीं होथिले आज्ञा करबाटा काडा बोली किना से मने बिटिके डाउट ने डरुथिले ना औ गर्भवती लोक राजी होथिले से मने भी नहीं बोलथिले आज्ञा चालू जे नहीं असुविधा नहीं है डॉक्टर मने आज्ञा मने कहि छ ना एठू जो वैक्सीन दबा को नउथलो लोकन को चिलिगुडा केते बाटा पउछ 10 किलो आ केते पैसा खर्च करथले सो गोटे अटू के 100-700 होले 3-4 अटू लागुतिला आज्ञा हॉस्पिटल को जुनागढ़ का खराब थले और गाना करबा आज्ञा बोही बुआ करने बात पड़छ तमर हेल्थ प्रॉब्लम काना चल नहीं पारबा नहीं पारबा आज्ञा केते वर्ष कोन हैला हाला ना बाबू 5 बच्चा की 6 बच्चा हाला ना दुईटा केंता ना और कैसे को घर के एले वैक्सीन लेला पर देह खराब लागी जर आन लागो आज्ञा वैक्सीन नहीं छ कतटा दुईटा इति कायला देले घरे देले ना जेतेले म लखना पड़ा गली 7 किलोमीटर चाली चाली जाई कि मदर मने मना करथिले तांको बुझेइलु किछि हबो नाही हाथुरो दार नथिला एठे भंडा जाथिला एटा काली रे जने झियो थिला तांको घर जाई कि ना घरे के देखना वैक्सीन आछा काटपुर जिगरो काली कार देखना संभव से झियो को देखना बेसी प्रॉब्लम दुंदेलमल पंचायत रो दुंडा एरिया रे टिके प्रॉब्लम हैला से नाम के प्रॉब्लम खाना कि पहाड़ चढ़ी कतो जिमा 4 किलोमीटर पहाड़ चढ़ के जाउथिले से नर एरिया रे लोक कथा भाषा चाली चलन हमर थार पूरा अलगा आशा दीदी से जगह थिले हमके बुझौथिले जे से माने काना कह आ गोटे गां अछि जोटा कि नै कि हावसपुर जिगरा सेटर हावसपुर नै कि सेटा गोटे मेंटल अछि सेठी से तांको कि वैक्सीन को जाउ नथिले कि तांको फैमिली ताको कि आन नथिले वैक्सीन बे ताको गोटे बंद कोठी रखाई छि ताको से नै कि वैक्सीन पे नाराज होथिला बाकी हमें साहस करी जाय कि ताको वैक्सीन करला
The community approach of Rupayan could convince even the most reluctant population to get jabbed. The NGO engaged local volunteers and grassroots health officials like auxiliary nurse midwives, ANM, and accredited social health activists, ASHA, workers to sensitize people on the benefits of vaccination. Before Rupayan's intervention, the percentage of adult vaccination in the Junagadh block was 64% and 21% for the first and second doses respectively. The vaccination rate drastically improved to 99 and 97% in the first and second doses respectively after the NGO took charge of the drive from November 2021 to April 2022. In July 2022, India became the second country to cross 2 billion marks in COVID-19 vaccination after China, thanks to the dedicated work of organizations like Rupayan and proper coordination between governments and NGOs.
Okay, thanks, colleagues. It's 7 minutes and a little more. And this was work of Rupayan, who will also meet Rajkishore Misra, who is the director, who will be presenting the Asia paper. But before that, I also thank Pragati Prabha, who did this video. I went to the place, collected the video, I mean, shoot it by mobile, but the whole direction and all is been done by Pragati. Pragati, if you can switch on your camera and say hi to everyone. Pragati is a journalist based in Odisha. Hi, Pragati. If you can switch on your camera and say hi to all. Say hi. You have to unmute. You have to unmute. You cannot unmute. Okay. Okay. Thank.
Good evening, everyone.
Yeah. Go ahead, Pragati.
Go ahead, Pragati. Half a minute.
Go
Good
ahead.
morning, everyone.
Go ahead.
Yeah, my name is Pragati. Actually, it was a great experience in doing this video. It was actually my first experience with the videos. My other two junior colleagues, they helped me a lot in doing this video. Actually, when tribal people are concerned, I am very much interested about the issue, because in this video, the actually the community approach of Rupayon that helped to eradicate their fear of vaccination, because tribal people are very reclusive in nature, and so far as we are concerned, we are like outsider for them. So when Rupayon hired the local people, the ASA and ANM, the tribal people, they actually familiarize with their own people. When their own people convinced them, so they were agreed for vaccination.
Thanks, Pragati. Thanks.
Thanks.
Thanks, colleagues. We'll straight go ahead to the. Okay. Thank you. Thanks, sir. To Rajkishore Misra, who will present the Asia position paper. Rajkishore Misra has worked on the Rupayan. In fact, he's the director there. They did this work, and I thought he's the best person to write this position paper and at the Asia level. So he is a social activist, but he is also known for his work on right to food earlier. He has been with us off and on the issue of vaccine inequality. So, Rajkishore, please go ahead and present your Asia position paper. Thank you.
Thank you, Pradeep sir. Actually, it was wonderful working with you in Junagadh for some time. Am I audible? Is it clear?
Okay. Very clear. Very clear.
So, once again, good morning, everyone. So, actually, everyone present here have had their own experience dealing with COVID in last 3 years. But we had the opportunity to work among community to ensure vaccination for all in the eastern province of India, that is Odisha, and we work in a area called Junagadh, that is a block of Kalahandi district. So that experience was really wonderful, and I'm really thankful to Pradeep ji and GCAP and other network partners who had given me this opportunity to document the Asia position paper. So it was a great learning experience. Actually, we had first-hand experience of dealing with issues relating to vaccination in one among the remotest area in Odisha. But while writing and this Asia position paper, I had the opportunity to consolidate what we did, and I could find that the situation across Odisha is almost similar. So I had given this task, also asked to limit it to 6-7 pages report. So it was not possible to document the wonderful experience of colleagues and friends working in other countries like Philippines, Sri Lanka, Nepal, Afghanistan, Pakistan. So I tried my best to document the gist of the experience we had gone through in last few years. So just coming to the point, so when we were working, we could see initially that there were demand and supply gap when it comes to vaccination, and there was a urban bias. Like in cities and towns only, there were centers where people can come and book their slot for vaccinations. During that time, there was the rural household and people residing in rural and tribal hilly terrains. They were actually not given the priority because of several reasons. And now I could understand that that was strategic also. Also a deliberate attempt to manage the demand and supply gap. So that was there. But when coming to COVID in general, so WHO was saying that compared to the SARS virus of 2003, the case fatality ratio for COVID-19 is less, but the transmission is very high. So that has resulted in larger number of deaths. Also, it has affected a large number of people. When we see the situation in Asia, there are few countries like Singapore and Malaysia, Thailand, Japan, where the first case was reported during January 2020. But the last countries where COVID-19 cases were reported was Yemen and Tajikistan. So if we generalize the thing, it was during February and March, this spread across Odisha. And at present, it has affected more than 637 million people. And out of those, almost more than 6.6 million deaths have been reported. And the share of Asian countries is around 1.4 million plus counting. It is still going on. But here we could realize that the reported cases are not the reality. There are many cases which has not been reported. So we know that due to lack of test and treatment, also due to other reasons, the death registers were not updated. So it is estimated that it is more than 4 times the reported cases has been the reality. So the reality and the reported cases, there is a huge gap. So that is there. And this is not limited to India or one country. It is almost everywhere. So coming to
if you touch upon the vaccination also, we'll have 2 minutes more for you. Sorry.
Okay, so the transmission coming to so I'm skipping many things because friends and colleagues from other country will cover that one. So coming to vaccination, there were vaccination hesitancy were reported in from almost all countries because of information and rumors. So that was there, but vaccine hesitancy was there. Vaccination priority was almost similar in almost all Asian countries. Like everywhere we could notice that the health worker and the public officials, those who were dealing with general public, were given the first priority, then followed by others like people, vulnerable people above 60 years of age, and that has a similar trend that is reported from almost all countries. But thing is that now at this point of time, we could see that there is still a huge gap when it comes to vaccination. There are many countries where vaccination, the percentage of vaccination is very low compared to other countries. So the inequality, what we are talking about the as member of GCAP and other network, that is a really valid questions. And initially we are thinking that this COVID is limited to some higher section of society or rich, But at this point of time, we all will agree that it has impacted the poorest most, and this suffering of the socially and physically vulnerable communities is more compared to other section of society. As per the report of Oxfam, there are around 147 million people in Asia who lost their jobs due to COVID. And when it comes to poverty, around 148 million people, those were pushed into extreme poverty. So these are the impact of COVID vaccination. Coming to what at this point of time, what we can suggest or what we can plan to move forward. Here, there are 2-3 things. Apart from vaccine, I feel apart from free, fair, equitable global distribution of vaccines and prioritizing countries those where vaccination is percentage of vaccination is low. Apart from that, we have to focus on 2 more things. That is how to ensure equitable access to therapeutics and diagnostic. That is test and treatment. Recent reports is suggesting that there were around 4 times more application for patent in WTO for therapeutics, like drugs and drugs meant for treatment. So this is the right time. Apart from vaccine, we should also focus on the other aspect of medicine, like therapeutics and diagnostics. So this is what the summary of the ACR report. Yes, I know that due to limited time and space, I could not cover all these things, but hope when friends from other countries will speak, they will definitely add to what I have not been able to cover. Thank you. Thank you, Pradeep.
Thank you, Rajkishorji. Thank you very much. In fact, I shared the final draft of the Asia position paper with you. Do not use it now till we actually finalize it. Some little bit change may be done, but otherwise it's near final. We'll upload it on our web. We'll upload also all other country papers on our website and send it together eventually in the email. Thank you. Then we go to Pakistan. Mariam, are you there to share the country position paper? I cannot see you. Otherwise, we'll go to India. Aditi, can you share your India position paper? 5 minutes, 5 to 6 minutes is good. Aditi Anand is the National Campaign Coordinator of Vadan Todo Abhiyan in India, GCAP India. Yeah, Aditi, thanks.
Hi everybody. I will turn off my video and speak because I'm moving up the video.
It's okay.
So the India position, I think the video and Rajkishorji's companies also touched upon contents of what I would also be speaking about. But yeah, so I think just starting with how the pandemic was responded to, the government did put in some efforts and did put in an infrastructure system in place to address the rising number of cases. But as we know, all the waves of the pandemic have adversely impacted the marginalized communities the most, and the general public at large. So, and more specifically, a large section of people, right from the beginning of the government's response, a large section of people of marginalized communities were being excluded. Migrant labor's crisis was one of the largest humanitarian crises we've seen in recent times, where thousands of people were stranded and with little or no assistance from the government. And they had to travel to their homes, fend for themselves all on their own. Once the assistance came also, it was mostly through civil society organizations and humanitarian initiatives. at least in the initial days, where the government response was slow and isolated to sections that didn't have a wider outreach. The funds that were collected under the PM CARES initiative, which was a publicly sourced fund where a lot of companies, organizations, individuals, everybody contributed. That is a questionable fund at this moment. Whatever assistance that was even provided out of that fund is known to be mostly towards the infrastructure. And then the government initiatives like an app called Arogya-Setu, which was aimed to tell you that who are, like, what number of cases are around you, just to prepare you and prevent exposure to the virus. It was an app-based system, so naturally it excluded a large section of society which did not have access to smartphones and internet access. Then once the vaccine response started, I think in India, when last year in 2021 January, the India's vaccination program, vaccine drive was launched, which was that's the largest in the world, and promised to cover everyone, specifically like marginalized communities, mainly migrants, nomads, refugees, homeless people, and everyone above the age of 18. The government also increased the testing capacity for COVID-19 related tests in 2021, and also launched a campaign called Har Ghar Dastak, which means which was aimed to do a door-to-door vaccination campaign and vaccinate all the eligible beneficiaries across India. So through these campaigns and through these initiatives, the absolute number of vaccine doses that have been administered is quite high. But in reality, the percentage of population that has received vaccination remains still partial only. Only 75% of the population has had at least one dose. 70% people have had 2 doses of vaccination, and the booster dose, the rate is quite low at just 16%. Additionally, there have also been cases where the Indian vaccine made by the Serum Institute of India, they had to dump 100 million doses of their vaccine after it expired. This is a case from this year in October, and it could have gone a long way to cover a larger population in India and the outside also. Yeah, and the production of Covishield has also now been halted because citing low demand. But like I said, there is still a large population that needs to be covered, and so there is. And then we also talk about in a paper about how overall there also needs to be a review of the health governance that is there. So because the initiatives that are currently being imagined, the government initiatives that have been announced are also largely focused on public-private partnership and blended finance models, which again move toward cross-border and black marketing. So there needs to be provisions which are more public-centric, people-centric, and less profit-centric. Just moving on to the recommendations quickly, the free and universal COVID-19 vaccination demand that has been there continues to be there because like I said, there is still at least 25% of the population which is not vaccinated at all. And from some preliminary surveys that we've conducted with the denotified tribes and nomadic groups in India, we found that a large population of them, around 20%, in a very preliminary analysis that I'm telling you, 20% of people have not been vaccinated, and the major reason for that is that they don't they said that they didn't know about vaccination. So there is a clear gap in the communication that is going and the efforts that have gone towards covering the marginalized communities in this policy. There are several CSO efforts that have been, like we also saw in the video, that CSO efforts.
Aditi, if you can come to an end.
And
Yeah,
just wrapping
please.
so sorry, yeah. So like the video also mentioned, there are CSO efforts that are going on, and these need to be recognized and supported by the government in whatever form they can. And there is a huge need to invest in health infrastructure to improve the access, especially for marginalized communities in the long run, and to prepare to have like a disaster preparedness in case another pandemic is here or any other disaster strikes. Thank you for this.
Thank you. Thanks, Aditi, for all those details. We understand that there are issues of last mile vaccination in India, even though the rate of vaccination is high. So do we go to colleague Hum Bhandari, who is the Executive Director of an NGO Federation of Nepal, to present the Nepal situation? Hum, over to you.
Thank you, Pradeep, and namaste, everyone. Can you see my screen?
Yes, clear.
Yeah, so I'm just going to present the civil society position paper on COVID-19 and vaccine inequality in Nepal. And I'll try to cover some major points. And so the position paper firstly makes some kind of context analysis of Nepal. And there, I just want to share some points that Nepal actually launched COVID-19 vaccination campaign on 27 January 2021. Actually, I'm just going quite ahead in terms at the stage of vaccination already, and actually I missed. I will not be sharing the situation in the earlier days, and how we actually came to the point when vaccine rollout actually happened. So when the vaccine was actually rolled out, there were several priorities, and firstly, health and social sector and frontliners were prioritized, and then people over 65 years old, then 55 years old, then younger age groups gradually. So and by now, the people, already, much younger age groups are also already covered. And so currently, so by July 2022 data, Nepal has already covered 86% with the first dose and 87% with the full dose against the targeted population, which is 12 years and older. The recovery percentage of COVID-19 patients stands at 98.6% in Nepal, while the fatality rate is 1.2%. I also have, I'm presenting some data from WHO that you can just see that, almost, 205.69 total doses administered, total 100 population. So just more than double, maybe because of the third dose as well. And so there were, different and quite many impacts of COVID-19 in different sectors of society, economy in Nepal, and damage to social and economic well-being and health. And this has been, analyzed in the opposition paper. So we observed that in the pretext of COVID-19, we observed a lot of, restrictions in rights and freedom and civic space. So we have studied, and there is a lot of information And we also made, a study of COVID-19 impact to civil society organizations, particularly at the earlier stages, how the funding and space for them was shrinking. And at the same time, although with limited resources, civil society organizations made their best efforts to support the government and working with different partners in order to address the impacts of COVID-19. So civil society organizations also, monitored human rights situation and civic space situation in the country in coordination with National Human Rights Commission as well. So there are a lot of issues like vaccine health and other issues. These have been analyzed at length in the position paper. So after the analysis of the situation, we have made 19-point recommendations. From those points, I have just picked a few, which I just wanted to highlight. One of the points that the recommendation highlights is that it's necessary to optimize and sustain the vaccine uptake system and capacity. So we observed that we were actually not prepared for the pandemics like this, but this situation has made us build the system and upgrade the system and capacity. For example, the cold chains for the vaccination supply. So they need to be sustained and optimized so that we can face such kind of disasters or situations in future. So it's necessary to develop and maintain vaccination plus strategy. So this has been a bit explained, and strengthening resilient health systems on the foundations of universal health coverage, grounded in human rights and gender equality. Robust procurement and supply chain management is necessary. So we also observe that because of very slow and bureaucratic process of procurement, there were a lot of issues in terms of procuring the emergency materials and supply and use of them. So our whole process was slowed, and there are a lot of things they need to be improved. So there are also demands that include suspending relevant intellectual property rights and TRIPS waiver in developing countries, especially the LDCs and poor economies, so that the medical supplies, medicine, and vaccines are available in an affordable price, even after the LDC graduation, particularly in terms of a country like Nepal. So preparedness, response plan, systems strengthening and recovering better have been emphasized, and specific and targeted poor health interventions are necessary, so that actually we have lost a lot of gains in terms of public health, because not only the COVID-19 but other health issues and problems were not properly looked after at that time, because people were deprived of going to or receiving emergency health services or regular health services at that time. We are also demanding enabling environment, acknowledgement, and role of CSOs.
Kindly wrap up in half a minute, yeah.
And multi-stakeholder engagement. So it's also necessary to enhance the health management information system and data impact assessment and lessons documentation, so that we can be better prepared to face this kind of challenges in future. Thank you.
Okay, thanks, Hum. You can also share your PowerPoint here. Thanks. Over to Abdul Awal. Awal Bhai is the director of Noakhali Rural Development Societies. He will present the Bangla position paper. Awal Bhai, over to you. Awal Bhai, over to you.
Good afternoon. Thank you, Pradeep, and warm welcome to everybody joining this wonderful webinar on the position papers we developed from each countries. In the interest of the time, I will present a very short overview of our country position paper. I have been trying to upload the screen sharing option, but I am facing a trouble. But I shared this in the chat box. If you kindly open that PVA presentation, then I'll be very happy. So in this short presentation, I would like to tell the background, especially how we developed this and what kind of focus we have given. Especially, we critically examine the role of state, global community, corporate agencies. The COVID-19 response is based on humanitarian position to ensuring available scientific knowledge, invention of vaccine and technologies, whether it is serving the humanity as a common public good. We know that the COVID-19 has accelerated and prioritized global health issues related to the global health architecture. Sustainable financing for health, equitable access to health tools, commodities, especially related to COVID pandemic. The main focus of the campaigners to building a global health service system resilience, harmonizing global health protocol standards, expanding global manufacturing and knowledge hubs for pandemic prevention. And the context in Bangladesh, we found that in March, beginning of March, we detected in February ending also a few, and largely we detected March 8, 2020. And since then, total more than 2 million people are officially reported as infected, and with 29,402 deaths until October 2020. So the observation is that public and private, both the health service positions were severely challenged by pandemic and resulted extreme vulnerability of the population in terms of unavailability of vaccine and medical technology like ventilator, oxygen supply system, spatially for treatment, and accessibility of the marginalized people to all those services. We know that the global death toll was more than 6.3 million formally, but if we examine based on all the model reaching estimate maybe 19.6 million, and 55% of the death tolls found in the low middle income countries, where the lack of vaccine, lack of technology and public service system was very weak. The invention of vaccine was great success of scientific knowledge system, but vaccine nationalism, business interest made it very difficult to reach most needful and equitable distribution system. While the world faced immense death toll, 40 new billionaires were minted just from profits of COVID vaccine, treatment, test, and PPE business. We know everybody. So the world experienced that the current global health architecture supply system is not working for the many, for as long as it is a system that puts profit before lives. For us, as long as it is self-serving science and private property and outsources pandemic management to a handful of companies only, who largely looked for their business and profitability over the humanity. I just will cite the example of Bangladesh response. Bangladesh is a highly populated lower middle income country, and overall population is more than 161 million, and we faced a real calamity. It has made a number of efforts to combat the pandemic: lifestyle adjustment, use of mask, movement restriction, quarantine of doubted people, isolation of infected patients, local and regional lockdowns, blah, blah. It's like any other countries. Government has taken emergency steps and formed national committee, response committee headed by ministry. The committee decided to close all the government private offices, including the education institutions, for a very, very longer period. Ban of all public gatherings, transportation service, suspension of all domestic and international flights, blah, blah. So these restrictive measures also undermined in some cases the civic space and role of citizens and others, but CSOs and NGOs have made very good contribution. So the government announced several financial stimulus, and like any other countries, and social protection mechanism, and the country was able to make not able to make proper strategies in a very puzzling situation. Later, the government, NGO, private organization, research organization, doctors together stands firmly to work for the humanity. The government procured vaccine, but not as per global commitment and agreement with different countries. In addition, limited testing facilities, inadequate treatment service, along with the absence of public awareness, avoidance were the major challenges to tackle the COVID crisis situation effectively. Although the government was facing challenges to control the pandemic, it shakes due to proper strategic planning, participation of citizens, and transparency in that tough period. And another one very important issue is the TRIPS issue that was the barrier to equity and justice in that period. Bangladesh made a demand in the 74th virtual session during 25th February 2022. And February, the world, even our Prime Minister in another virtual message, she requested to the global community for TRIPS waiver. Bangladesh has called for a temporary waiver under the agreement on TRIPS for promoting local and production of vaccines, medicine, and other health technologies to effectively respond to the pandemic. Bangladesh has capable to producing vaccine, therapeutics, and diagnostic and other medical equipments that should get licensed, as well as technological leverage and technical know-how to produce the vaccines and health technology, etc. So Bangladesh called for paying due attention to the need to ensure sustainable funding from WHO, and low-income countries have requested a temporary patent waiver for vaccine at the TRIPS Council. We know the situation, what TRIPS Council, they announced that decision taken that LDCs are not obliged to patent drugs, but there are some complications. We know, and we discussed that and critically examined that as a PVA in Bangladesh and in Asia level. So in that follows the patent waiver will not be applicable for Bangladesh after 2026. We know I'm not going that far. And now I come to the point of vaccine administration, where we found some inequality in health service provisions. Out of 70% vaccination target, WHO global target, the first dose against population is now 87.23, and second doses administered 73.79, and the third dose administered 48. So the first and second dose, we crossed the target, and Bangladesh is very hopeful. But there are still many difficult to reach populations, including some elderly people, more vulnerable communities, Adivasis, Aboriginal people. So the recent data has shown that about 60% of all those aged 60s and over have yet to be vaccinated in Bangladesh, with some citing a lack of information and about where and when they can get the vaccine. So it seems that deepening inequality and injustice among the vulnerable communities, age groups, in terms of the total health service provision that are not equitably accessible by all. CSOs considered the whole process was not inclusive and responsive to providing public service delivery effectively. During the COVID-19 pandemic, the Bangladesh schools have been closed for more than 445 days since the pandemic started in 20. According to the study, 37 million children in Bangladesh were affected due to the school closures during that period. The COVID-19 pandemic restrictions have made access to services very difficult and have highlighted the gaps in resources available to combat domestic violences, especially violences against women. Local authorities, police become burdened with relief distribution, and limited number of shelter homes stopped taking in new survivors due to lack of testing kits and fear of COVID contamination. Lockdown measures have made it difficult for survivors to access an equity through governmental channel. I'm just going to close the discussion that how this vaccine equity should work as a right to health of citizens. Right to health is guaranteed in the Constitution of Bangladesh. The country have public health service from village to the sub-district, district, and national level, but inefficient government system and lack of qualified doctors, budgetary provision for improved health service system is now very crucial. Growing policy of privatization and commercialization has undermining the rights of the people. The healthcare treatment, preventive vaccine is not privilege, but a human right. It should only be provided on equitable basis, regardless of race, color, religion, sex, language, political, ethnicity, and other opinion, national or social origin, property, birth, and other status. PVA Bangladesh, through consultation, tried to draw the attention of policy leaders to ensure vaccination for all. Waiver of the trade-related aspects TRIPS agreement for COVID-19 vaccine is estimated to meet the number of doses of vaccination required to achieve global herd immunity, according to the joint article. South Africa, India in October 20 submitted a proposal to the WTO to temporarily
wrap it
Yeah,
up.
just closing. It is the last slide. It is the just last slide. And the COVID-19 pandemic reveals the incompetent healthcare system in Bangladesh. And pandemic put some health systems under immense pressure and strained others beyond their capacity. As such, responding to this public health emergency and successfully minimizing the impact requires every health resources to be leveraged. Failure to protect healthcare in this rapidly changing context exposes health system to critical gaps in services, including decreasing public health expenses. Different studies identifies three responsive issues for the country's deteriorating healthcare system, including poor governance, increased corruption, inadequate healthcare facilities, and weak public health education and communication that should be addressed by CSO initiative and citizen movements in Bangladesh. This is our short overview of our country position paper. We will be sharing our full position paper very soon. Thank you very much for giving some more minutes. Thank you.
Thank you. All right, it was nicely presented. Now, without wasting more time, I'll go request Resma Sakya, the program head of SAAPE, to present the Sri Lanka position paper. Resma, also try to keep it within 5 minutes. We'll have other colleagues to present you. Resma, if you are speaking, we cannot hear you. Or unmute and speak. Please unmute the two Resmas. Yeah, now you are unmute, okay. Resma, we cannot hear you. Maybe you can try from the other one, the mobile connect, from your mobile. Can't unmute. I'm now asking you to unmute. Okay, report was to unmute.
Hello.
Yes,
Hello.
yes. Now.
Am I audible? Yeah, there
Yes.
is some confusion. I am using two IDs, so there is some connection, audio connection in my laptops. Sorry for the confusions. Thank you, Pradeep. Hello, everyone. SAAPE, as a member of the People Vaccine campaigns, took the initiative to organize the research of the COVID-19 pandemics and the vaccine inequity in Sri Lanka. And we have prepared a position papers to bring into light the issues of vaccine equity by assessing the internal dynamics of the country where vaccine equity could have been the case, possibly because of disproportionate access to vaccine doses based on income, class, caste, religion, and other socio-economic factors. So I'm going to present the major findings and recommendation which we prepared as a Sri Lanka position papers, and it also provide the useful recommendation to civil society to take forward some issues regarding strengthening the public health sector. So our report on the COVID-19 pandemic and vaccine equity in Sri Lanka. Regarding the COVID-19 pandemic in Sri Lanka, as in usual in other countries, the first case was tested positive on 11 March 2020, and the table shows the different waves of the COVID-19's spreadness, duration from the 2020 to 2022, and the number of cases, number of deaths we can see in the tables. When we observe the tables, we can see that Sri Lanka having able to control the pandemic well in the first wave, but was unable to maintain the same control during the third wave of the pandemic, that causing unacceptably high rates of infections and deaths due to the COVID-19. We can also note it from the report that Sri Lanka's fatality rate due to the coronavirus is one of the highest figure among South Asian countries, being second only to Afghanistan. Similarly, while regarding the government response, as in other countries, there was travel restrictions, quarantines, closure of schools, offices, and different types of the rigorous surveillance mechanisms, contact tracings, hospitalized all COVID positives. The first formal health sector plan in response to the pandemic, the Sri Lanka Preparedness and Response Plan, COVID-19, was released in April 2020. Similarly, in March 2021, President of Sri Lanka appointed two separate bodies. That was the National Operations Center for Prevention of COVID-19 Outbreak and Presidential Task Force. While talking about the impacts, the most of the impacted sectors are the informal sector workers, tea plantation sector workers, fisheries sector workers, and poor vulnerable peoples. The informal workers, many of whom are low-income earners, often do not benefit from the formal social protection systems that exist in the country. Informal workers suffer from loss of earnings during the pandemic, and even within the formal enterprises also, there are informal workers that are not protected by written contracts and may be bearing the brunt of the impact. Those who lost their jobs in formal sectors do not have access to job-linked social protection benefits like unemployment insurance. Similarly, the fishing communities, they are enabled to go to the sea, disrupted the whole fisheries value chains, decrease in the consumers' demands, and steep decline in export. And while talking about the impact on the poor vulnerable peoples, According to the World Bank analysis report published in 2020, the COVID-19 crisis increased the international US dollar 3.20 poverty rate from 9.2% in 2019 to 11.7% in 2020 in Sri Lanka. This change translates into over 500 million new poor people. And regarding the effectiveness of the government support mechanism during lockdowns, due to the sudden lockdowns and curfew in March 2021, created a panic buying and shortage of the essential consumers items. As a response from the government for this, government had made arrangement with vendors to deliver essential items to household. Similarly, there was a cash grant scheme with one-off payment of LKR 5,000 to vulnerable groups in April 2020, which somehow alleviate the suffering to some extent. However, many
in interest of time, if you can actually touch upon the vaccine situation and then close.
Okay,
Sorry,
okay. Then I will skip some slides of the
in
vaccine.
1 minute.
Yeah. While talking about the vaccine equity, as of 14 August 2022, a total eligible population in Sri Lanka, that means the 12 years and above, 78% received the first dose and 66.4% received in second dose. However, the booster dose was received only by 36.75% and second booster dose by fraction of the population, that is the 0.28%. As of tables, we can also see in the tables, by 14 August 2022, a total of 49,735,513 doses have been administered. Out of the total, 90% of vaccination were carried out by the health staff, while 10% was administered by the tree forces and the police. And political economy of vaccine and its impact on the Sri Lankan situations. From the beginning, vaccine rollout in Sri Lanka, civil society has expressed serious concerns about the lack of transparency in vaccine selections and the procurements, deployment plans. Procurement guidelines provided extraordinary powers to the government to make emergency procurement through any means of necessary. There was no proper accountability or oversight mechanism in place to safeguard public interest in the vaccination process in Sri Lanka. Sri Lankans have not shown much hesitancy towards the vaccination in compared with other countries, but there are some myths and challenges or misinformations regarding the vaccinations. Some have the trust in the indigenous medicines, that people's attention from the vaccine leading to vaccine hesitancies. Similarly, there are some conspiracies about the Pfizer vaccine is rapidly given as there is a stock which is supposed to expire soon. These are some misinformation which gives some hesitancy to taking the vaccination in Sri Lanka. While talking about the vaccine and the WTO framework, Sri Lanka has not used strict flexibility for vaccines or any other messaging to this date. And vaccines comes as a donation through COVAX, WHO, UNICEF, and other bilateral arrangements. As a state policy, Sri Lanka provides universal free healthcare to the public. Following this policy, government of Sri Lanka is obliged to provide COVID-19 vaccines to population free of charge. The NVDP has estimated the appropriate cost of procurement of vaccines outside COVAX and bilateral donations, and it's costing $7 per vaccine dose and $2.4% for vaccine distribution administration. And Sri Lanka has received vaccination from a combination of sources: COVAX, direct donation, direct procurement using government funds on grant from the United Nations and the bilateral agencies. Are some loans from multilateral agencies such as the ADB. And the gaps in the government policy and implementation contain the spread of the virus, the approach to prevent and control.
I think you should wrap it up now. I'm sorry.
Okay, then I will directly go to the recommendations and CSO's key acts to the government and the international community. There is some recommendation and CSO's key acts which report has mentioned. some setup of independent mechanism to monitor public perceptions and make appropriate recommendation to the government and other stakeholders to initiate timely actions, review the existing social protection systems in Sri Lanka, set an integrated coordination mechanism building on the UNSCT cluster mechanism where the government, CSOs, private sectors, and development partners can work together the pandemic preparedness and response. Similarly, the public and the donors demand full transparency in the procurement and distribution process of the medicines, vaccines, and device. Thank you. That's most from my side.
For this one question, you have free vaccine? All the vaccines are given to the people for free, or people are charged?
No, it's a free vaccines. It's a vaccines, but I'm just showing the costing of the vaccines that government has to
That's for the government.
bear. Yeah.
Okay. So
Okay,
Resma,
I
please
have
share this PowerPoint in the chat for colleagues who wants to take it.
Yeah, I will. Okay, thank you. Thank you, guys.
Thanks. We'll go over to Mr. Asutosh, who is from Asia Dalit Rights Forum, who will present a position paper which is done on the issue on the position of Dalits in 4 South Asian countries: Pakistan, Nepal, India, and Bangladesh. Asutosh ji, over to you. You can stop sharing, Resma. Mr. Asutosh, okay. Yeah, please. We cannot hear you, Mr. Asutosh.
Hello?
Yes. Please go ahead.
Thank you. Good morning to everyone. I will be focusing on COVID and Dalits in South Asia.
Yeah, please go ahead.
As we know that COVID-19 was a pandemic, but it was made a human crisis. Human crisis in the sense that the structural inequality which is present in South Asian society, coupled with apathy of government, it made it into a human crisis. This recent Lancet report told that so many deaths could have been averted if government act quickly and in planned manner. So in South Asia, as of 10th October 2022, more than 5 crore people are infected and deaths are more than 6 lakhs. There is no segregated data on caste, but believing the social position and structural inequality in our in South Asian society, we can find that the number of cases and deaths could have been more among vulnerable communities. South Asian Justice Society has done a survey of 419 households, and they found that 51% in India and 81% in Pakistan were COVID affected. It shows that the Dalit community and vulnerable communities were mostly affected. I will deal with the impact of COVID-19 in both a direct impact and indirect impact. It means that one is that when the people were most susceptible to the COVID-19 because of the housing condition, the availability of water and sanitation, poor per capita income, low nutrition index, prevalence of communicable diseases and non-communicable diseases. This made the marginal community more susceptible to the COVID-19, and it was the result that they succumbed to succumb to death. After COVID-19, there was great what you call shutdown, in which it affected the economic very seriously. As India was the center of both the waves, the economic slowdown was seen in whole South Asia. The GDP rate went down to minus 6%. The inflation rate rose in every country, and there was rising public debt also. Informal sector was vastly hit due to this COVID shutdown, and medium and scale industries were totally shut down. So informal workers were the one who lost their job. As we can see that in South Asia, 88% workforce are involved in informal sector, and mostly Dalits and vulnerable communities are all involved in informal sector. So there is no, in South Asia, we can't find employment protection, social security, security in this sector. So they are basically on contracts or on non-contracts. So the result was that most of them lost their jobs. Poverty rate increased among them. Unemployment rate was high. Rate was high according to in South Asia. According to ILO, 315 million lost their jobs. And according to Food FAO, 320 million people globally were added newly under food insecurity, and in that 30.4% are from South Asia. The government relief measures were not very not adequate. They were short term, and because of planning and non-participation of community, the relief measure couldn't reach to the Dalit community. I will go to the vaccine because I have very less time.
Yeah.
You can see that there is alarming gap between high income countries and low and medium countries. We have done survey like till now, till September, as for government data, 68.75% in India are vaccinated. In Bangladesh, 75% are vaccinated. But when social justice task force did a survey, it found that there is a gap between the government data and what we surveyed. Like there was 5 to 10% gap. We can see that in India, 21% of people were not vaccinated. Nepal, 5% were not vaccinated. In Pakistan, 39% were not vaccinated. There were 955 CDWD respondents. We did survey on 31st till 31st October. So we can find that there is a gap between those one for those 1%. In those one, there were many people who have taken, but those 2% gets down to low, and for the booster, it is very low. We can see the children also. In children, we surveyed. We can clearly see that in India, 47% of children were vaccinated. In Nepal, 67%. In Pakistan, 10%. And in Bangladesh, 49%. So children are not 18 plus are not vaccinated. Below 18 are not vaccinated. So what are the challenges actually? We have all other presentations have already said that low awareness, superstitions, and there is also for vaccination, internet, smartphones were used for registration and updates. It is and we can see that in South Asia, poor people don't have that smartphones or that connectivity to the internet. And that is mostly resides in exterior area, in rural areas and remote locations. So to reach them is very difficult. Also, for some vaccines, the pricing of vaccine is also done. Vaccine camps are done are not done in the very proper manner, and is not decentralized. People participation is very low, so that's why it is not reaching to the desired community. And in other countries, there is no supply of vaccines because of trips. Many countries like Nepal, Pakistan, they rely on China and India for vaccines or for other donor countries.
So Toshji, can you wind up in half a minute, please? Really,
For what are the recommendation? We find that disaster risk reduction capacity building for DWD communities should be done, and there should be some dedicated fund for to speed up the vaccine process. And we have the vaccine should be inclusive, and it should be universal coverage without any pay. And for the effect of social economic effects of the COVID-19 shutdown, there should be economic packages given to them, and that should be at long-term plan.
okay.
And we can also find that health infrastructure should also be developed, because we find that in remote locations there is no health centers. So and in South Asia, the expenditure of health sector is below 3%, is around 1% only. So health infrastructure investment should also be increased. There are lots of implementation. I thank you for giving.
Thanks. Toshji, nice presentation. Can you please share this PowerPoint in the chat box for the colleagues to refer to? Thanks, colleagues. We do not have colleagues from Cambodia. Prague informed she won't be able to join. Some other meeting urgent, and Philippines and Pakistan have some emergencies. Mariam and Tessa. So we are done with the presentations of the country position papers and Asia and Dalit position papers. We'll have 5 minutes for question and answer, and then we'll go to lunch for 2 more agenda. So floor is open for questioning or any very short, crisp response. Or if you want to tell something on COVID and vaccine situation, it's most welcome. Manish, Ola, Jared, who else are there? Nilufarji. And Stanley sir, you have any response? Or you want to tell something from India perspective or any other? Okay, if we are happy with all the presentations, then we could go to the next agenda. So Lance Espacio is the coordinator for People's Vaccine Alliance. He will deal with 2 agendas. One, in PVA Asia, we are thinking now to change our focus a little bit, not exactly change, but add some more. And then we are thinking of doing a short statement based on the webinar and the position paper. Lance, over to you. Have full 15 minutes. I hope you can manage with that.
Right. Thank you, Pradeep. Can you see my screen, the slide?
Yes.
All right. Thank you. Thank you so much, Pradeep. And thank you to all who have shared in this session. I know a few minutes isn't enough to capture the extent of the work that you've done throughout the time that you've been working on the papers that you've just presented. So I really appreciate the sharing of the files, and after this webinar, we will have a better look at them. And really thank you for all the work you've done. We hope that the process that you've undergone in writing these national papers have been fruitful for you and valuable also in terms of reflecting on our experiences during the pandemic, and also reflecting on the ways forward. And that's something that we at PVA Asia, myself on behalf of course, the Secretariat, the Steering Committee, and the broad membership is also undergoing such a process of reflection and evaluation and in identifying how we can adapt to of course, the nature of the advocacy we have is ever changing. The pandemic itself is changing month by month, week by week, and that's really the context of the campaign that we've brought together. And as Pradeep had mentioned at the beginning of this session, PVA really is at the regional level a loose campaign coalition, a diverse organization of various civil society organizations working on so many issues on social justice, on health, working with vulnerable and marginalized populations. And I think this is an opportunity for us to recognize the work and the diversity of this alliance, and really reminding ourselves of the importance of the work and what's there that we are facing from here on. So let me share with you what we we're a regional coalition, yes, but we're also part of a global coalition. And some of the reflections that in terms of our priorities as a global alliance, let me share with you some of these points, as a result of the reflection and identification of ways forward. So three things that we've identified as part of regional processes in Asia, in Africa, in Latin America, and also with global colleagues based in Europe and North America, based in the global North. Really, this is the result of a collective reflection of our alliance as a global one. We've captured or attempted to capture three really global priorities that we hope we also would reflect on ourselves and how we can contribute to the advancement of these priorities. So I'll explain each priority, but in summary, these are three. Never again, fix the rules, and then also public health before profit. Before I begin explaining each priority, just to put a note here that because of the diversity of our coalition, we're working on various issues in the region, and also nationally, right? This doesn't mean kind of like a top-down, this is what we should do, but rather in terms of focus as a global coalition, these are the three things that we're focusing, but of course, not preventing others from, of course, working on other issues that might be relevant in the region and also nationally. We're also fully supportive of the work that you're also doing. So in terms of the first issue on Never Again, really this is a result of our reflections on the experiences during the pandemic, about the weaknesses in our health systems, really reflecting on being better prepared for future pandemics. Right, we as a global campaign coalition would like to ensure that the response to the next pandemic does not repeat the same failures that we've seen during the COVID-19 pandemic. I believe it's the first time we've, in recent memory, that we've experienced such a pandemic that has high transmissibility and affected many populations of this scale and magnitude. So learning from the mistakes that governments and institutions have committed, we hope to apply those in reflecting on better preparing, preventing, and responding to the pandemics from here on, right? And from the region, from Asia, we hope to look at spaces such as the Pandemic Fund from the G20 and also the pandemic treaty negotiations at the World Health Organization. And look at these spaces and see how we can precisely promote our interests, as civil society, as those representing local communities' interests, how we can push for that, especially in our region, right? And so we've been doing that and will continue to do that through the G20 at the WHO, the regional hub offices or of the WHO, and we've also made our voices, or tried to make our voices heard in these spaces. And another priority, secondly, is in terms of continuing our work in terms of challenging trade and intellectual property barriers and pharmaceutical industry behavior that continue to restrict access to life-saving medical technologies for COVID-19 and other diseases. Part of our reflection is that also moving beyond COVID-19 as the disease, we're also looking at other diseases such as HIV/AIDS and reflecting on the same barriers that we as a collective are also all facing, especially in the health sector, right? And in terms of our regional contributions to that priority, and then we've seen that also with the immense and invaluable amount of work you've done nationally, is to continue demanding Asian governments to remove IP barriers at the World Trade Organization, and nationally also consider, all right, there's one piece of work on pushing governments to pursue compulsory licensing on countries who have manufacturing capacity. We heard a while ago Bangladesh had some level of manufacturing capacity in India, in Indonesia, and in these countries we were looking at really supporting the work in terms of licensing and advocacy in that regard. Another piece of work in our campaign is at the region, campaigning for the recognition and acceptance of locally produced vaccines, therapeutics, and diagnostics. We've seen, for example, in terms of hesitancy in acceptance of vaccines, that the brand matters, and then there are other factors, right, that determine the acceptance of vaccines, part of which is the support for those vaccines that might be indigenously produced or locally produced in our region. We hope that moving forward, those would be better supported, and so that we would have better access to vaccines, therapeutics, and diagnostics in the future. And finally, thirdly, a third priority issue would be in public health before profit. I remember one of you also mentioned quite strongly that we want a global health architecture that works for the people and not for profit. So that's something we're continuing to push as a regional campaign, building on the work we've done by pushing, again, public policy in order to build equitable access to medical technologies for all. That includes at the regional level, looking at manufacturing capacity and also orienting pandemic preparedness, recovery, and response initiatives to supporting community-based and community-led approaches. We've seen how civil society has filled in some of the gaps, in terms of the last mile vaccination, in terms of right, reaching out to the most vulnerable. And so that's a reflection we'd like to bring to the table in terms of access to medical technologies, that civil society, not only government, has a role to play in terms of pushing for access to medical tools. So I end with that. Three priorities I've shared with you. Again, these are not to say that these are the only things we will be working on as PVA, but rather as a global campaign, have a bit of a steer, a guidance, a focus, right, in terms of our work. But again, given that this is a collective response, we encourage you to continue engaging us in conversation, developing further recommendations and suggestions, and really developing campaigns that are most relevant to us, especially in the developing countries. So your papers would be really helpful also in terms of making the issues we're campaigning on more responsive and more relevant to what's really happening on the ground. Let me conclude by also sharing with you some resources that I will also share maybe through email or through the chat. These are resources that have been developed as a result of the collective work of regions and also the global allies, basically containing some of our key policy recommendations on various spaces. These are quite lengthy documents. These are policy documents, really, but I do hope that in your advocacies at the national level or at the regional level, these could be potentially useful for you as resources, which contain in part some of the things that you have also shared in this webinar. So I end with that sharing. Sorry to be very rushed into presenting the three priorities that we at PVA have conversed about, and really Pradeep had also mentioned we had hoped to maybe develop a statement out of the proceedings of this webinar. But that's something I'll do after this webinar. Maybe just getting the recording and getting maybe some of your quotes, really important ones, because now at the moment there's a pandemic treaty meeting also recently concluded, and also negotiations at the WTO. We were thinking that that some quotes might be relevant to respond to those processes, but I'll save that for after this webinar, as we're also running out of time. But if you have any questions and comments, really we're very welcome to hear from you, and thank you for all your work. Yeah.
Okay, thank you, Lance. Thank you. Thanks. I think, Lance, the statement that we'll be putting forward need not be very long. We have already some Asia position paper, and then some of the elements that we are also getting as next year focus for. So one pager can be developed, and I would suggest that we take all our colleagues as all the core organizers as proposer for the statement. And once that is ready, we can share that with all our colleagues here for endorsement. We can also share with the wider membership in Asia SDG platform, and there are several other platforms where I have shared this webinar invitation. That's why we have colleagues who are not very closely associated but have joined because of the wider civil society groups that we have in Asia. So with this, I will also share all these, the national positional papers are all there with us. The Asia position paper is in a final stage. We may add a little bit, but they will all be, we'll also design it. Once they're uploaded on the website, and then we can share with you. That will probably be more appropriate. We have already shared the Asia position paper here. So colleagues, if do we have 4 more minutes? Is it all right that we do a statement? And if any one or two colleagues have any last words on the issue? Okay, if not, then we'll bring it to a close. So we'll wait for Lance. Maybe Divine will work closer with Lance to develop the statement. Now, Lance, you will do the statement, then we can see it. So we'll wait for Lance to share the statement with us, and then we can endorse it. Thank you, colleagues. Over to Sat for the thank giving. Resma, you can unmute from one of your IDs. Okay, I'll ask you to this. Okay,
Yeah,
now.
it's unmuted. Thank you, Pradeep. Today we had a fruitful discussions, experience sharing, and sharing of the position papers on COVID-19 pandemics, its impact, and vaccine inequality in Asia. I wish to thank our speakers, presenters, whose presence has been invaluable in making the webinar a successful. As we know that after the rollout of the COVID-19 vaccines, people expected to get a vaccine dose at the earliest possible in a free and fair manner, irrespective of the national borders. However, vaccine hoarding, stockpiling, vaccine nationalism, and blocking the sharing of the vaccine manufacturing technology with the countries without such capabilities remain major hurdles against achieving vaccine equity. The inability of the states to rise above the use of life-saving vaccine as a political tool and the vaccine manufacturing companies' never-ending desire for profit have failed the humanity. So we have a fruitful discussion on these issues, and we would like to express our gratitude to all the participants for their presence and contributions. And we must thank organizing team for our work, for working hard for the past few days to make this webinar successful. And we are sure that the issues, reflections came out during the webinar will be helpful for our upcoming vaccine equity campaigns. Once again, thank you, everyone. Thank you so much for joining this webinar.
Thanks, Resma. Thanks all colleagues. Also, importantly, the colleagues who do mostly background work, the preparations. And Divine, if you can switch on your video, and Jared. Divine is the comms person for GCAP, and Jared is the comms person for People's Vaccine Alliance Asia. Jared, if you can switch on your video and say hi. Thanks, colleagues, for also attending this. We keep in touch, and we continue our work with more wider focus that Lance shared. Okay, thank you, colleagues. Bye bye. We'll share the recording also. Thank you. Thanks,
Bye-bye.
sir. Good to see you.
Hello, thank you, everyone. Thank you.